Hi, I'm Dr. Monty Pal, and I'm a medical oncologist at the City of Hope Comprehensive Cancer Center. On behalf of myself and my co-authors, I'm delighted to present this data related to lenvatinib at 2 starting doses in association with everolimus in patients with advanced renal cell carcinoma. I'd really like to thank the Kidney Cancer Association for the opportunity to present what I think is very important work here. Now, as many of you know, lenvatinib at 18 milligrams with everolimus at 5 milligrams is currently approved for the second-line treatment of advanced renal cell carcinoma following one prior anti-angiogenic therapy. As you've seen in the previously published study 205, lenvatinib with everolimus was associated with a 14.6-month progression-free survival as compared to just 5.5 months with everolimus monotherapy, translating to a hazard ratio of 0.4. Having said that, lenvatinib and everolimus treatment resulted in a high percentage of patients with dose interruptions and reductions that amounted to about 89% of the population, or treatment discontinuations in 29% of patients. So this presentation really focuses on an opportunity to really assess two different dose levels of lenvatinib at either 18 milligrams and 14 milligrams, and see if we can potentially get around this hurdle. This is the study design. It included patients with advanced clear cell kidney cancer that had progressed on one VEGF prior directed therapy or more treatments. And in this study, patients were randomized with stratification factors, including MSKCC prognostic group, as well as exposure to prior PD-1 or PD-L1 directed therapy. Patients received either lenvatinib at the approved dose of 18 milligrams per day with everolimus at 5 milligrams per day, or a reduced dose of 14 milligrams per day with everolimus at 5 milligrams per day. Now, very importantly, in this particular study, if the drug was tolerated for a span of 4 weeks without intolerable grade 2 or grade greater than or equal to 3 treatment emergent adverse events, patients were allowed to escalate, or mandated to escalate, in fact, to 18 milligrams daily. The primary endpoints in the study were efficacy with an objective response rate as of week 24. And the analysis here is tricky. I'm going to go through that in just a moment. And also safety, being the proportion of patients with intolerable grade 2 or any grade greater than or equal to 3 treatment emergent adverse events, again, at that 24-week milestone. Now, just another word on the primary efficacy endpoint. We utilized a non-inferiority test here. So the null hypothesis is that there's an odds ratio with the 24 milligram versus 18 milligram dose of less than or equal to 0.76, the alternative hypothesis greater than that number. Now, here we used a one-sided p-value mandating that it needs to be less than or equal to 0.045 for non-inferiority to be declared. Okay, very important. The primary safety endpoint was based on a superiority test as delineated here. Now, importantly, this study was initially designed as a double-blinded study. However, we encountered some issues with the computer assignments of dosing that affected about 33 patients. Now, importantly, no patients were assigned a dose level exceeding 18 milligrams per day. Although we initially had 306 patients planned for the study, we actually extended the enrollment to 338 patients to account for these issues with dose assignments. So as you can see here, we've divided our analysis into the per protocol analysis set, and that excludes the 32 patients where there were reassignment errors by the computerized system. That includes a total of 311 patients. We also had a full analysis set, including 343 patients. The per protocol safety analysis set incorporates a total of 309 patients. The demography of our patient population is what you might anticipate for patients with advanced renal cell carcinoma. You can see here a median age ranging from 61 to 62. Most patients were male in this cohort. You can see that approximately 30% of patients were favorable risk based on MSKCC prognostic groups. And prior nephrectomy was performed in the vast majority of patients. Prior PD-1 and PD-L1 based therapy, which we'll touch on in just a moment, was rendered in between 25 to 30% of patients included in this experience. And when we look at the prior number of anti-cancer therapy regimens, you can see that most patients received either 1 or 2 prior lines of treatment. Now, this again was the primary endpoint of the study, response at week 24 based on investigator assessment. And you can see that the response rate was 32% with lenvatinib at 14 milligrams versus 34.8% at lenvatinib at 18 milligrams. Now, we may look at this as being sort of a marginal difference. The odds ratio here is 0.88, but keep in mind that we were looking for a p-value of less than 0.045. Here we achieved a p-value of 0.2676. So what we've essentially defined is that that 18 milligram dose is not non-inferior in this particular case. When we look at the overall tumor response rates, and I'm going to just dive down to the bottom half of this table where we define the objective response rates here, you can see a modest difference between lenvatinib at 14 milligrams and 18 milligrams with a response rate of 34.6% and 40.6% respectively. The median duration of response similar between both arms at around 11.5 months. As we look to the forest plots over here, really hard to tease out many meaningful differences across this population. One might suggest that those individuals with baseline hypertension and those individuals with prior PD-1 or PD-L1 directed therapy, that really sort of reflects a contemporary population of patients, are those that seem to benefit perhaps to a greater extent from lenvatinib at 18 milligrams. The waterfall plots here really reflect the response rates that I defined previously. You can see a larger proportion of patients at the 18 milligram dose with a greater than 30% reduction and frankly greater than 50% reduction in tumor as you look towards these plots. And this is the data for progression-free survival. You see a progression-free survival of 11.1 months with lenvatinib at 14 milligrams versus 14.7 months with lenvatinib at 18 milligrams. In terms of overall survival, if you really pick apart these curves, you can perhaps see a slight trend that favors lenvatinib at 18 milligrams once again, although it's hard to make heads or tails of this, and certainly this probably needs a bit further follow-up. Now, what about tolerability? As you recall, this was another one of the primary endpoints of the study here. As you can see, subjects with intolerable grade 2 or any greater than or equal to grade 3 treatment emergent adverse events at 24 weeks was similar, if not slightly higher, with lenvatinib at 14 milligrams at 82.8% versus 79.6% with lenvatinib at 18 milligrams. The p-value here is 0.47. In terms of the median duration of treatment, you can see it was 7.7 months with lenvatinib at 14 milligrams versus 8.18 months with lenvatinib at 18 milligrams. You can see here a median dose intensity at both 14 and 18 milligrams that range between 13 and 14 milligrams. And the proportion of patients that received the median lenvatinib dose as a percentage of planned dose was 76% at 14 milligrams, similar at 18 milligrams. Over 90% of patients received the intended doses of everolimus in this experience. In terms of dose reductions, you can see that the frequency was similar at 14 milligrams and 18 milligrams at around 65%. And in terms of the median time to first dose reduction, it was approximately 2 months. I'm going to jump down to the bottom of this very busy table that outlines the summary of treatment emergent adverse events. And you can see that ones leading to study drug discontinuation slightly higher with lenvatinib at 14 milligrams, 32.4% versus 26.8% at 18 milligrams. Treatment emergent adverse events leading to dose interruptions, again, higher now with lenvatinib at 18 milligrams, 83.3% versus 74.6% with lenvatinib at 14 milligrams, and no real meaningful differences between the treatment emergent adverse events leading to study drug reductions. What about the most common treatment emergent adverse events ranging to greater than 20% in either arm in this study? You can see that the most frequent ones, as you might anticipate with this regimen, were diarrhea, hypertension, proteinuria, and decreases in appetite. And in terms of serious treatment emergent adverse events, you can see that these occurred in 49% of the population, 49% of the population receiving lenvatinib at 14 milligrams versus 48.8% receiving lenvatinib at 18 milligrams. I'll let you sift through the individual adverse events as listed here. So I know this was a very rich and busy data set, but to summarize, non-inferiority cannot be claimed for the starting dose of lenvatinib at 14 milligrams versus 18 milligrams. And again, that's on the basis of us seeing this very slight difference, 32.1% for lenvatinib at 14 versus 34.8% for lenvatinib at 18 milligrams, with an odds ratio of 0.8, a p-value here of 0.2676. I will say that perhaps this suggestion is bolstered by the fact that we see a progression-free survival and overall survival that seem to trend towards favoring lenvatinib at 18 milligrams. I would suggest, after really diving deep through this data, that there are no significant differences in the proportion of patients with grade 2 or grade 3 treatment emergent adverse events within the first 24 weeks, and therefore no true differences in safety as I looked across these populations. And therefore, in amalgam, I think that these data really support the current dosing regimen of lenvatinib at 18 milligrams per day with everolimus at 5 milligrams per day for patients with advanced renal cell carcinoma following one prior anti-angiogenic therapy. I'd really like to thank, of course, the patients and families that contributed so much to this study, as well as the investigators and their teams who contributed to this effort. I'd like to thank the study sponsor, ESI, as well as Merck. And also, I'd like to acknowledge the medical writing and editorial support proposed and used in this presentation. Thank you very much.